Thanks, Dr. Amol. Good evening to all of you, and I pray that we all stay safe in this crisis period. I welcome all the panelists and all the faculties and all those who are attending this meeting. So I have been assigned to discuss a few points regarding the immunotherapy role in stage 3 NSCLC. So when we talk about the immunotherapy in the stage 3, we usually think that is the concurrent CTRT in unresectable disease followed by consolidation immunotherapy. Is this the only topic in the stage 3, or there are the other ways to incorporate the immunotherapy in the stage 3? So rather than going through the some case discussion, I will be discussing the few points which has been answered so far and which I believe is still not answered. So let's have the few points. And stage 3 disease is not so uncommon in India. Indian data say that compared to the West, almost similar, 25 to 30% of the patients are in the stage 3 or unresectable stage 3 patients. So when we have the stage 3 patients, we always try to dissect out the resectable versus unresectable patients or the potentially resectable patient, which we try to give them the neoadjuvant chemotherapy to make them the suitable for the surgery or surgery followed by the adjuvant chemotherapy presently. Now, those patients who are potential candidates for the new surgery, and few of them are being selected for the neoadjuvant chemotherapy. So I would like to ask my panelists here that there are many trials ongoing for the chemotherapy plus minus immunotherapy in the stage 3 patient, not only the early stage patient, but even the stage 3 like 3A or 3B patient who may be tomorrow suitable for the surgery or being considered for the surgery. So presently, are you thinking or are you trying to incorporate those patients in the routine clinical practice for the chemo plus minus immunotherapy, or still you would like to wait for the results of the ongoing trial where you would like to incorporate them with the chemotherapy for the immunotherapy? So what's your thought process, or are any clinical trials feasibility available at your surrounding or at your center where the chemotherapy plus immunotherapy is being considered upfront in the form of the neoadjuvant treatment? Any panelist can take up this question. So my panelist available here?
Yeah.
Yes, Dr. Mansi, please.
Yeah. So, Mani, so till now, actually till checkmate 816, we just had data saying that yes, there may be some improved trend in pathological complete response or major pathological response, right? Only one trial, I think NADIM trial, had EFS as an endpoint. Rest all of them just had pathological responses as primary endpoint. Now with checkmate 816, that's the first randomized control trial, that phase 3 trial that has reported its data, and it's shown a fantastic, benefit of chemo immuno combination over chemo alone in terms of improving the response rates. I think it was to the tune of almost 2% versus 24 or 25% of pathological complete response. So the other point is that this is very encouraging. It looks fantastic, but we don't have any survival data, long-term survival data. And in such a, like I presented that talk earlier, in these patients where we're looking at long-term outcomes, especially with regard to toxicities and long-term toxicities, this does become important. So I for one think it's encouraging, but maybe not to be used in a routine clinical practice till we get some more information.
One more comment from any panelist, then we move to the next part.
Yeah, not yet in routine clinical practice, as Madam said, that we should wait for the results and more phase 3 data.
So well taken. As on today, it's not the standard of the care, but yes, it seems that it will be, the data will be available. And similar to the neoadjuvant, we have the many trials of almost all these PD-1 or PD-L1 molecular inhibitors. They are being studied in the adjuvant setup also. That is the chemo plus the immunotherapy also, with almost similar primary endpoint or the similar secondary endpoint. So what's your thought process? Are you enrolling any patient, any group of the patients, or any trial available, or it is still in the part of the clinical trial, or you are not offering your patients in the adjuvant setup? Dr. Prakash?
In the context of only clinical trial, not in practice.
So Dr. Murtaza or anybody else would like to take up any comment on this particular adjuvant chemo plus minus immunotherapy?
Yes, as Dr. Prakash said, in context of only clinical trial setup, till the routine data is encouraging, or many results are still to come into the. But till then, we are going to just adjuvant chemotherapy, or in both neoadjuvant and adjuvant setting.
And to best of my understanding, I don't think that presently any clinical trial is ongoing in India regarding adjuvant chemo plus immunotherapy. So that's another story. So now coming to the core point of the today's discussion, that is the locally advanced NSCLC stage 3, which is definitely the multimodality treatment and to be evaluated carefully. And those patients who are being selected for the concurrent chemo radiation, that is our dream to treat the patient. Yes, but sometimes we try to give them the sequential chemo plus RT. So definitive CT-RT is the standard of the care in the unresectable stage 3 of the patients. So when we choose these patients for the radiation plus chemotherapy, how do you go for the chemotherapy part? It is purely the histopathology based, or you keep the in your mind that tomorrow you are going to give this patient the consolidation immunotherapy arm also. So is that point going to make any impact in selecting the chemotherapy arm or chemotherapy drugs or the chemotherapy schedule? So Dr. Meenakshi can take up this question. Dr. Samiksha, sorry, I'm sorry, Dr. Samiksha. Dr. Samiksha Dubey from Nagpur is available for the panel discussion.
No, sir. She will be joining.
So from Raipur, Dr. Suman Mittal is with us.
No.
She's also not there. And what was the Dr. M.V. Chandrakant from Kolkata?
Yes, I am there, sir.
Yeah, welcome.
So, it's a good evening. So, as you very correctly said that should I choose my chemotherapy backbone depending on whether I give IO or not? Because there is some evidence that if I give a taxane platinum in the concurrent setting, the incidence of radiation pneumonitis is higher. Therefore, it would be ideal if I can choose a etoposide platinum rather than a paclitaxel if I am giving durvalumab in the post CTRT. So this is a good evidence, but as of now, we are using taxane platinum weekly, irrespective of whether we use durvalumab or not. So
can I ask at the other end of the country from Mumbai, Dr. Nandini Menon, that what is her experience of giving the pemetrexed plus platinum followed by immuno-oncology drug, especially for the non-squamous histopathology patient? Dr. Nandini Menon is available. So if she is not there, yeah. Any of you can take from this question regarding histopathology-based chemotherapy, especially in the non-squamous cell NSCLC regarding the pemetrexed platinum. The only thing which I want to bring in the highlight is that we most of the time try to give the paclitaxel and especially the weekly to avoid the toxicity of the fear of the toxicity of the 3-weekly schedule. So that has shown the inferior result compared to the other. So as being commented clearly that it's better that you give the cisplatin etoposide sort of the combination, and then you try to give to the immuno-oncology drug. So are any of you practicing these points in the stage 3 NSCLC, like giving more chemotherapy after radiotherapy, trying to increase the dose of the radiation, or trying to add some newer drugs like cetuximab?
No, sir, no.
So these are none of us are practicing like giving the more chemotherapy as the consolidation, which previously we used to give like 2 more cycles of the chemotherapy as the standard of the care or sort of consolidation arm. So none of our practicing. So now we all are aware of the data, like the role of the immunotherapy, that is the durvalumab in the consolidation, especially those patients who had the CR, PR or minimum stable disease. We now have the beautiful data in form of the progression-free survival as well as the overall survival. And we have talked a lot among the various trials, various platforms, webinars, and the conferences over the last 2 years or more, and we all are aware. So now the question comes here is that with this PFS and overall survival from the Pacific trial, which are available to all of us, what is your opinion regarding these PFS and overall survival? Are you convinced, or still you feel that the certain subsegment of the patient, the data of the PFS and overall survival available are not convincing to choose for each and every patient? Dr. M.V. Chandrakant.
So yes, sir, the way we have survival in this subgroup is an unmet need. So for a long time, we had never seen such an improvement in survival. Yes, durvalumab must be used in all patients post CTRT. However, in those subgroups, if there is PDL1 negative, and if there is a driver mutation like an EGFR mutation, so in this subgroup, how beneficial it is right now is a point we need to discuss. Otherwise,
can we go to Dr.
Yes.
Manish Mathankar from Nagpur?
Yes, sir.
Yeah, please.
I think that till now the 3-year results of Durval consolidation treatment with durvalumab has suggested the good PFS and overall survival. And last year actually RTOG 0617 trial was also published, which was only with the CTRT. So this trial has suggested that their 2-year survival was almost comparable with the durvalumab consolidation trial. So I think we should wait till the 5-year result comes. Hello?
Yes.
Yeah, I'm audible. Yeah.
So anybody would like to contradict this statement from the panelist?
As I'm Dr. Murtala. As there is no other drug till now is available for us. So and this data PFS and OS data is still very encouraging for us, and especially stage 3 NSCLC which are not which are unresectable. So I think if there's no any drug is available, we should go with the durvalumab in the suitable patients. As the PFS is almost more than double for the compared to the CTRT. So I think we should go for durvalumab, and still there's a data is lacking on the PDL1 negative side. So, but we can use durvalumab in as a consolidated set.
So moving to the next part of our treatment strategy in the CTRT and immunotherapy in the stage 3. So the classical, that is the standard trial says specific that it is up to 42 days post CTRT, you evaluate the patient and try to give it. So how early or late you would like to start your patient in this? How do you feel it? You want to start it very early or as soon as possible, or you want to give the enough time at the end of the 42 days and then you want to start, or even you would like to take your patient at the end of the 3 months? So Dr. Murtaza, I would like to start with you.
Yes. As some data shows that if we start the treatment before the 14 days or before the between 10 to 14 days, there's a results are more encouraging compared to the if we start after 42 days. But we have to keep in the mind that the patient will be ready for taking this treatment in the form of this PS and in the blood parameters, or all the toxicity as the radiation with the chemoradiation has gone till the date. So if a patient is well enough ready for taking the treatment, I will start the treatment early compared to going to late.
So we have with us from one of the busy center of the high volume center, Rajiv Gandhi, Dr. Mansi Sharma. So can you throw more light on this question? What is your experience? That what is your policy that when you want to start the treatment? Dr. Mansi, please.
Yeah, so I agree with Dr. Murtaza. It's data does show that the earlier you start, the better it is. Would want to start as soon as possible, preferably within the first 2 weeks. If not, then yes, 42 days as was there in the trial. But if a patient is, I would not take that 42 days as a cutoff. Probably if the patient is not, he's not. There are some issues with starting at that particular time. There are some toxicities which are still resolving. We need to give the patient more time to recover. Maybe go up to maybe 6 weeks or I would say 6, 8.
So let me go to
we
Dr.
can
Manish.
just step forward a little bit more. Yeah.
So let me go to the Dr. Manish. Dr. Manish, there is a patient from Nagpur, and because he's diagnosed and very rich patient, and he went to Mumbai for the CTRT, and once CTRT finished, he comes to back you after 2 months, back to the Nagpur. Now, would you counsel this patient and would you like to start the consolidation durvalumab at the end of the 2 months?
I initially said that I will wait till 5 years data. Still, if I am in favor of durvalumab, so the trial suggests that even after the 42 days, there are 40% of the patients who have started after 42 days post radiation. So I think there is a scope. If we want to consolidate with the further treatment, I would counsel him to meet my medical oncology colleague and for the opinion regarding the durvalumab.
So the real world data are here for the large number of the patients, where approximately 40% of the patients they were enrolled in this trial, the registration trial or the data enrollment system, where the patients were more than 42 days, and the results were more and less similar or comparable with the original registration trial. So that is the important thing. Only thing that we need to discuss with the patient, the various implications of this, including the what we call that reimbursement system. So that's about this. And coming to the next part, as you people commented that you would like to start early as possible, but we should not forget that the data available are simply the provocative data. They are not the confirmatory data, and it is very difficult that you evaluate the patient at the end of the 15 days after the completion of the RT, and the patients are fit enough to go for this treatment. And sometimes we see that the very early start of the next treatment may land the patient in the various toxicity, but we need to discuss that the early incorporation in form of the concurrent CT-RT with immunotherapy, followed by the continuation of the consolidation arm in form of the immunotherapy. So that has been assessed in the many trials, ongoing trials like the Deterrent trial, LUN-14 trial, and the Pacific 2 trial, and so on. So the data are right now not mature enough. Now, important question is, stage 3 patient underwent the biopsy, sent for the various molecular tests, including the PDL1, and the PDL1 is negative, and you have given the concurrent CT-RT, patient has shown the very good partial response, and now ready for the consolidation. So what is the implication of the PDL1 status as on today in your mind? So let me go first to Dr. Manish Mathankar.
Sorry, hello.
Yes, Dr. Manish. So PDL1 negative patient, will you counsel the patient for the consolidation durvalumab as on today?
Yes, sir. As per my reading, even in PDL1, there was no correlation with the PDL1 testing and the durvalumab. It has shown the good result in PDL1 negative also.
So Dr. Prakash, what's your opinion?
Of course, I will check PDL1. If it is less than 1%, I will not give consolidation with durvalumab. Or other factors are also there, because our practices like financial constraint patients are more. So of course, with the seeing EGFR or PDL1, accordingly I can decide whether to give or not.
So Dr. Mansi, I can see you in the deep thought process. You have any comment here?
So I kind of agree that yes, there was only a PFS benefit that was the PDL1 negative population. It didn't really translate into a proper OS benefit. But this was just a small patient subgroup analysis. And if I remember correctly, they managed to do PDL1 testing only on some 65% of patients. They didn't manage to do it in all of them. So it's very iffy data. Having said that, like for example, Europe doesn't really recommend. I mean, they don't give it in patients less than PDL1. I would discuss with my patient, look at their affordability, tell them that the data is very iffy. We are not very sure that it translates into an OS benefit, and keep it a little gray, maybe not black and white.
So Dr. M.V. Chandrakant, the Bengal people has shown the different opinion very recently. So what's the opinion of Dr. M.V. Chandrakant on this point regarding the PDL1 negativity and enrolling the patient blanketly for the durvalumab arm?
Dr. Somani sir, last 5 minutes to conclude, please.
Okay, please. Dr.
So
M.V. Chandrakant, quick
yes,
comment.
sir. I agree, sir. In PDL1 negative population, the benefit is not that great. But even then, as of now, I would offer, because there is nothing else that with which you can improve this patient's on.
So then another important question is that the stage 3 biopsy is done, and then we send the patient for the various tests, molecular tests, or maybe the limited platform, maybe the NGS, and we have the EGFR, ALK, ROS1, BRAF. These are the, I think, the commonly done so far. So there are data available regarding your EGFR, which the patient has been incorporated, analyzed, and the subset analyses are available. So my question is that what is your thought process on those patients who have the rare mutation like ALK, ROS1, or the BRAF mutation stage 3 positive, and you have given them the concurrent CTRT, and now patient is willing to go for the consolidation durvalumab. Dr. Mansi, again. Suppose the patient has the ALK or ROS1 or the BRAF positivity. Any one out of these three. Forget the question of the EGFR.
Okay, so that's a tough question. The trial did not really look at biomarker selected population, so we don't know the correct answer to that. There has been some data recently which said that yes, these patients maybe don't do that well. Also, there are trials running. So coming to the second part, we do have some trials which are coming up with Ross and Rett at least, I think. So, I mean, we will probably end up doing and putting them into those arms if possible.
So on my screen, yeah, please, sorry.
So not very convinced about immunotherapy working in patients who are biomarker positive population. EGFR definitely no, since you already took that part out. I'm not very sure right now.
So
I
on
think
my
I would
screen-
probably give the patient a benefit of doubt.
On my screen, I can see Dr. Murtaza Bora, very relaxing, cheerful mode. Probably maybe the post is celebration. So what is your thought process?
The same as Dr. Mansi said, the still data is not in the trial. They have not included any biomarker positive patients. So as a EGFR, you have clearly out the question. So then, if still a patient is ALK, BRAF, or a rare mutation is positive, if the patient is affordable or there's no any tolerable issue, I will give immunotherapy consolidation. There's no other drug is available till now for
So
such type of the patient.
let's move quickly because we are now not having the much time. So we would like to conclude that yes, immunotherapy in stage 3, it is there, especially in the consolidation for our routine clinical practice. And the next last question to all of you for the simple comment, you all can take one by one. Does your treatment remain the same in this COVID period? All of you can make the comment. Stage 3, NSCLC, consolidation, durvalumab. Is your treatment going to remain the same, or are you really finding the patient for this? Dr. Murtaza, please start.
Sir, as in this COVID era, the relatively patient number is less in the clinics compared to the previous time. And if the patient is on the treatment, this patient becomes the COVID positive, or after the completion of the CTRT patient becomes the COVID positive, then I will wait more time to resolve the issue or to patient to recover. Then I will think of any type of consolidation therapy.
Dr. Prakash, please.
Yeah, nothing to
Sir,
add.
last 1 minute to conclude, sir.
Yeah. So anybody else on this last question or the last thought process?
Sir, I would offer durvalumab, sir, because this adds life to the patient. This improves OS and PFS. So we should not delay or defer durvalumab in this COVID era.
So keeping the time in our mind and as being reminded again and again, we would like to conclude here. Thanks to all the panelists and to all those who are participating. And once again, on behalf of my panelists, I would like to thank organizing team to give us this wonderful opportunity. Thank you.
Thank you very much, Dr. Naresh Somani sir, for this excellent panel discussion, case-based discussion on stage 3 NSCLC with immuno-oncology. So we'll move on to session 3, which is a post-EGFR session. And we have 3 abstracts to discuss in this session. So first, I would like to invite Dr. Vivek Agarwala, who is a senior consultant medical oncologist at Department of Medical Oncology and Hemato-Oncology, Narayana Super Specialty Hospital, Kolkata. And Dr. Vivek Agarwala will be talking on phase 4 trial of afatinib followed by osimertinib versus osimertinib alone as first-line therapy in patients with advanced EGFR mutation positive NSCLC. So over to Dr. Vivek Agarwala.
Yeah. Hello, am I audible?
Yes, Vivek, you are audible.
Yeah, thanks a lot. Thanks a lot. Thank you, Dr. Amol and Dr. Nikhil, for giving me this opportunity. Without wasting much time, I'll go ahead and discuss this act, which was presented in the ELCC 2021. So it is a phase 4 trial of afatinib followed by osimertinib versus osimertinib alone as first-line treatment in patients with advanced EGFR mutation positive non-small cell lung cancer. And this is just a proposed study which is going on without any results. So I will be just presenting the study design. So we will have to first look at the background and try to spend some time more on the background of this study. So we all know that TKIs are the way to go for treating metastatic EGFR mutation positive non-small cell lung cancers. And the first generation TKIs are now out of the race in the first line setting, because from the combined data of the Lux Lungs 3 and 6, we know afatinib is superior to chemotherapy in first line, and afatinib is somewhat superior to the first line first generation TKI based on the Lux Lungs 7. And then we know from the Archer data that is superior to first generation TKI in overall survival. And we know from the Flora data also that osimertinib is superior to first generation TKI, that is Jeff. So now probably we are more in the race whether to start with the second generation TKI or whether to start upfront with the third generation TKI. And then there are additional options of first generation TKI plus VEGF inhibitors and first generation TKI plus chemotherapy. If we evaluate all the three TKIs, what we know is that the second generation and third generation TKIs are more potent and irreversible, whereas the third generation TKI have less side effects because they don't target the wild type EGFR, but third generation TKI are more specific for T790M mutation, and they have a strong blood-brain barrier penetration. Now, the molecular mechanisms of acquired resistance is very important because they are different when we are giving our patients first or second generation TKIs. That is, most of these patients, more than around 50 to 60%, have T790M as the most common acquired mutation, and therefore we can easily target these patients now with osimertinib. And the other mutations are also there which can be targeted accordingly. But if we are giving a third generation TKI, that is osimertinib, in the first line, then the acquired mutations, when they are resistant to osimertinib, are mostly unknown, and very less than 10 to 15% of these patients are actually eligible for further oral TKIs, whereas most of these patients are eligible mostly for chemotherapy. And we all know in our clinical practice how difficult it is to treat patients who have progressed on osimertinib. If we look at the Flora data and see what was the second line treatment, so this is what we see is that in osimertinib arm, 47% patients received second line treatment, and 68% of the patients actually received cytotoxic chemotherapy, whereas in the first generation TKI arm, it is most of these patients, 47%, actually received osimertinib, and only 22% received cytotoxic chemotherapy. So time to TKI is more when they are giving TKI followed by osimertinib. So if you look at this treatment sequence, what is proposed is, if you are giving a first and second generation TKI, and if you have a T790M mutation positive, you can give osimertinib, and then later you can give on chemotherapy. Whereas if you are giving osimertinib, then on progression you have to straight go ahead to chemotherapy, except rarely if there is a molecular target. So this was the basis of the GeoTag study, which actually looked at the efficacy of sequential treatment. So it was an observational retrospective study where they looked at the EGFR mutation NSCLC patients who were given first line afatinib, and if they had a T790M mutation, then they were actually treated with the second line osimertinib. So they looked at these patients, and what they found was that the overall time to TKI failure, that is the time on TKI, was 27.7 months in the overall population, which was really good. And the overall survival that was found was 37.6 months when we were giving first line afatinib followed by. So this is the basis of the current study, which is ongoing in, they are already recruiting patients since June 2020, and it's going in 8 centers in Germany. So it is known as AFAMOC, which is a prospective randomized multi-center phase 4 trial, which is assessing the sequential afatinib followed by osimertinib in patients who are developing T790M versus osimertinib alone. So this is the trial schema. So they are taking mutated EGFR mutated patients of advanced NSCLC. And they are randomized 2:1 to either afatinib or osimertinib. And in the afatinib arm, if on progression they are T790M positive, they are treated with osimertinib, whereas in the T790M negative, they are treated according to the physician's choice, whereas in osimertinib arm, when they are progressing, their treatment is according to the physician's choice. These are the key inclusion and exclusion criteria. So baseline T790M mutation they are excluding, and if they are receiving thoracic radiation or they are having surgery, they are excluding, whereas they are including patients of brain metastasis also, and ECOG PS 0 to 2 is included. Patients have to be TKI naive. And these are the primary endpoints. So the primary endpoint is not overall survival. It is time to EGFR TKI failure within 24 months. That is, at 24 months, what is the time to TKI failure for afatinib followed by osimertinib in the T790M positive versus osimertinib. Secondary analysis, they are looking at time to EGFR TKI, PFS, OS, response at 12 and 24 months, disease control rate, safety, tolerability, and all this. And they are also having a translational research component where they are looking at what is the baseline EGFR mutations as well as the secondary mutations or the acquired mutations later on resistance. So if you look at the critical analysis, well, this is a good prospective randomized study, asking a very valid question, because there is no trial yet which is comparing second generation TKI versus osimertinib in first line in a prospective setting. So it is a good and a valid question, but the trial has several limitations because it is not probably asking the correct question. The primary endpoint is not overall survival. So because of this, they have taken the primary endpoint is time to TKI failure at 24 months. And if it is already biased in favor of the afatinib followed by osimertinib sequence, because from the geotag we already know that the total time to TKI is the 27 months, whereas if you are taking osimertinib, then the median PFS is 19 months. So most of the patients would be on TKI if you are doing afatinib followed by osimertinib sequence. And therefore, that is the reason why the sample size is very less, that is 126. So, it may not carry that good clinical value. If it would have been overall survival as a primary endpoint, the trial would have had a higher sample, but it would have been more valid and more relevant. That is, what I feel. On discussion, I think there are a lot of factors which make us decide what is the first line treatment in EGFR mutation positive advanced lung cancers. What is the type of EGFR mutation? What is the treatment efficacy, safety, presence of brain metastasis? What is the ECOG PS? What is the age? And definitely we have to think about the subsequent treatments, because the treatment parameters and the acquired treatment patterns are definitely dependent upon what will be the acquired resistance. And our first line drug is going to change the type of mutation that is going to happen. And post osimertinib progression, we all know it is a difficult to treat population. It is a valid point to save this drug for the only T790M mutated population. So till further results, my take is that in exon 19 mutation, I think osimertinib still remains a very strong and preferred first line choice. In L858R mutation, I think there is no OS advantage with osimertinib, that is quite clearly seen with the FLORA data. But dacomitinib, when we look at the Archer data, it looks to have a very good data. You know, the forest plot shows further towards the left towards the dacomitinib in the L858R subset, but they have excluded brain metastasis. So in L858R with brain metastasis, probably I would go with afatinib or chemo plus gefitinib or erlotinib plus VEGF inhibitor. And if it is, if there are no brain mets, then I would go with dacomitinib in L858R subset. And for the rare EGFR mutations, except T790M, then I think afatinib is the way to go. So I thank you all for patient listening, and I thank the organizers again for giving me this opportunity. Thank you.
Thank you, Dr. Vivek Agrawal. So we'll move on to our next presentation, which will be delivered by Dr. A.P. Dubey. He is a consultant medical oncologist, hemato-oncologist, and bone marrow transplant specialist at Shanti Mukund Hospital, Delhi, and he'll be talking on a Destiny Lung 1 trial, which is a phase 2 multi-center open-label 2-cohort study of trastuzumab deruxtecan, an anti-HER2 antibody drug conjugate for HER2 overexpressing or mutated, unresectable, and metastatic NSCLC. So over to Dr. A.P. Dubey, sir.
Good evening, everyone, and thanks to Dr. Amol and Dr. Nikhil for giving me this opportunity. They have told me to present Destiny 3, but due to lack of data, I couldn't. So with the informed consent of the organizing team, I'm presenting Destiny 1. So as we know that understanding the molecular pathogenesis and the pathways which drive malignancy, we have developed many targets which could be interrupted to inhibit the further downstream signaling and thus control the tumor growth. And among those, HER2 is one of infrequent but emerging actionable molecular target in advanced non-small cell lung cancer, accounting for around 2 to 6% of lung adenocarcinoma. In contrast to breast, here HER2 mutations are being commonly been observed and noticed, which are seen in around 2 to 4% of lung adenocarcinoma. Presently, there is no direct HER2 targeted therapies which are approved for this particular subset. In phase 1 study, patient with HER2 mutated non-small cell lung cancer had confirmed objective response rate of more than 72% with trastuzumab deruxtecan. And about Destiny Lung 1, it is an ongoing multi-center phase 2 study in patients with HER2 mutated as well as HER2 overexpressing non-squamous cell, non-small cell lung cancer who have already progressed on standard lines of therapy, chemotherapy or immunotherapy. So this is the schema of this open-label multi-center phase 2 study, where the patients with diagnosed non-squamous non-small cell lung cancer who have already progressed on standard line of chemotherapy, oblique immunotherapy, and are HER2 expressing or HER2 activating mutation. Cohort 1 was HER2 expressing IHC 2 plus or IHC 3 plus, whereas cohort 2 was HER2 mutated. These patients were offered trastuzumab deruxtecan at 6.4 milligram per kg every 3 weeks. Surprisingly, the primary endpoint is not overall survival, but it is overall response rate by independent central review, whereas key secondary endpoints contain duration of durability of response or duration of response, PFS, OS, safety, disease control rate, and so on. So these are the eligibility criteria which I have already discussed in the schema. The patient should have diagnosed metastatic non-squamous non-small cell lung cancer and has been already progressed on prior standard line of chemotherapy or immunotherapy. Cohort 1 HER2 expression, HER2 overexpression, whereas cohort 2 is HER2 mutation. These are the exclusion criteria on your right side. The patient should not have received HER2 targeted therapy or should not have any cardiovascular morbidity, including QTc prolongation more than 450 milliseconds. Also, because one of the worrisome adverse events seen with this particular drug is interstitial lung disease. So patient of interstitial lung disease are being excluded from this study. So these are the demographic and baseline characteristics. Majority of patients were Asian and females, and all the treatments, all the patients have received at least 2 lines of prior therapy, and most of them, around 90%, have already received platinum-based therapy. These are the efficacy result, which is of cohort 2, where the patients of HER2 mutated non-small cell lung cancer were being taken. The confirmed overall response rate you can see is 61%, 26 of 42 patients, whereas disease control rate in around 90, more than 90% of the patients, and DOR is not reached, and progression-free survival, median progression-free survival is 14 months. Here you can see the median progression-free survival offered by this particular drug is 14 months, whereas median overall survival is not yet reached. So in palliative setting, we are not just concerned about progression-free survival, overall response rate, or overall survival. We are also concerned about the toxicity profile. We have to maintain the quality of life in the patient. So this is the overall safety summary of this particular drug. I must tell you here that this drug is unique in its own kind. It's a antibody drug conjugate with very potent drug and very high drug is to antibody payload of around 8:1. Drug is to antibody payload here is 8:1. The drug payload here is deruxtecan, which is topoisomerase 1 inhibitor, which is very highly potent and also with a very short half-life. Short half-life is been kept so that the adverse event because of such high payload is less to the non-tumor cells. Also, it has got a stable linker, which is quite stable in the plasma, and only it is cleaved by the lysosomal degradation in the tumor cells. Also, one more thing, it has very high membrane permeability. So thus, a bystander killing effect is very much prominent. So these are the few unique characteristics of this particular antibody drug conjugate. So about the overall safety summary, the median treatment duration in the all, it was more than 7 months. The most common adverse event which has led to the dose reduction were fatigue and nausea, whereas the most common adverse event which has led to dose interruption were low neutrophil counts. So the most common adverse event which occurred in around more than 15% patients were gastrointestinal and hematological adverse event, also fatigue, but they all were low grade. You can see that the green is grade 3 and 4, whereas the blue one is grade 1 or 2 adverse events. The more deadlier adverse event which has been associated with this particular antibody drug conjugate is ILD, interstitial lung disease, which is seen in around 11% of the patient. But majority of the patient recovered either without any sequelae or with certain residual sequelae of this particular drug, or what you can say the interstitial lung disease. So any patient who have been receiving this particular drug, a very close monitoring has been kept to diagnose this particular adverse event at a very early stage, so that this particular deadly adverse event is being prevented. So the median time to onset of this reported interstitial lung disease was 86 days. 4 patients had drug withdrawn and 1 had drug interrupted, and all patients had to receive steroid treatment. So to summarize, so this I have presented only cohort 2 study, cohort 2 results, which is been also expanded with an additional 50 patients to better characterize the efficacy as well as the safety profile of this particular drug in this subset of the patients. To summarize about this drug, that HER2 mutated non-small cell lung cancer are very rare, accounting for around 4 to 6% of adenocarcinomas. But there's an unmet need of certain effective targeted therapy in this particular patient, because these patients are being treated with the chemotherapy and immunotherapy. There is no presently FDA-approved drug for this particular subset of patients. So trastuzumab deruxtecan, which is a unique antibody-drug conjugate, has demonstrated clinical activity in this interim analysis with an overall response rate of 61.9%, with median DOR and overall survival not reached yet, and estimated median progression-free survival of 14 months. The safety profile of in this HER2 mutated cohort was generally consistent with what was been previously reported with this particular drug. And also the majority of the patients who had adverse events were low-grade gastrointestinal hematological adverse events, and also fatigue, which could be easily manageable or managed. The most worrisome is the interstitial lung disease. So the careful and very close monitoring to diagnose this particular adverse event at an early stage is warranted. So this, at last, this data demonstrate the potential of trastuzumab deruxtecan as a new emerging treatment option in the patient with HER2 mutated non-small cell lung cancer. So the further data will come up and it will make us more wiser to choose or to guide treatment in this particular subset of the patient. Thank you. I again thank the organizing committee to giving me this particular opportunity to present this data. Thank you.
Thank you so much, sir. Thank you, Dr. Dubey, for this wonderful presentation. We move forward, and I invite Dr. Sushant Mittal, who is a senior consultant medical oncologist at Action Cancer Biology Hospital. Over to you, sir, for your presentation. Dr. Sushant Mittal, sir.
Thank you. Thank you so much. Thank you, organizers, for inviting me. I'll just share my screen. So the topic given to me is role of circulating markers in predicting immune-related adverse events and their recurrence in advanced non-small cell patients. So why are we discussing this is because immune checkpoint inhibitors have radically changed the management of lung cancer, and timely recognition and management of these immune-related adverse events is essential to avoid life-threatening events. At present, we don't have any markers which are available to predict the onset of these side effects and the recurrence risk. Therefore, it adds to the economic burden to the patient when these side effects occur. Already these drugs are expensive, and then they have to get admitted for the side effect profile. For the management of these side effects, it adds to their cost. So the aim of this various studies which I am going to show is to evaluate the potential role of circulating markers in predicting the adverse events related to immunotherapy drugs. This is one of the papers from Italy by Alberto Pavan, which showed that a retrospective data was collected from August 2013 till April 2018, and the criteria was clinical database, adequate follow-up, treatment with checkpoint inhibitors according to clinical practice, minimum follow-up of 3 months, and a control group patients who did not receive immune checkpoint inhibitors. Drugs included were Pembro, Nivo, Atizo, and it was given until radiological or clinical progression was there. The methodology was data was collected on type, severity, and timings of adverse events. Calculation was neutrophil to lymphocyte ratio and platelet to lymphocyte ratio. From the simple CBC what we get in our OPDs on regular basis, on that basis NLR and PLR was determined. It was done before the administration of first drug was administered and at the onset of adverse events. NLR was calculated as absolute neutrophil count divided by absolute lymphocyte count, and the cutoff was 3, and platelet count versus divided by lymphocyte count was PLR, and the cutoff was 180, high or low. Study population, majority had adenocarcinoma, Driver mutations had very few, about 7% of the patient had driver genomic alterations. Majority drugs given was nivolumab, and NLR was high and low in equal number of patients, and similarly PLR was also 50% and 40% in the defined category of the patients. As the results showed that about 32% experienced different types of adverse events. Median onset was about at the end of 3 months, and 40% developed within 12 weeks of the first dose of immune checkpoint inhibitors. As we can see from the graph, majority had pneumonitis starting from grade 1 till grade 5. Diarrhea was seen maximum up to grade 3. Similarly, increase in lipase amylase was seen in grade 3 and about 40 to 50% of the patients. Skin-related events was maximum in up to grade 2, and endocrine-related, in which hypothyroid was majority of the events which was seen. It was grade 1 was maximum, about 66% of the patient. So when the data was analyzed, it was seen that patients who had low NLR had more chances of having immune related side effects. Similarly, patients who had low platelet lymphocyte ratio again had more chances of receiving immune related side effects. And these was associated with the baseline low NLR and low PLR. So if at the start of the drug, if the low PLR and NLR was there, patient had a more chance of receiving of getting immune related side effects. However, this graph showed something else. It showed that patient who had low NLR, meaning who had more adverse events, had a better PFS and overall survival. Similarly, patient who had low PLR had a better overall survival and PFS. So this was not explained clearly in the paper why it was so. They just mentioned that it was a retrospective study, and this is one of the findings which they found out. They had updated the analysis again, in which they had shown that another 304 patients were taken for analysis, and the median number of cycles were 6. So median PFS was 5.5 months and overall survival was 21 months. About 38% developed immune-related events, and 85%, as I showed you to the graph, had grade 1 or 2 side effects, which is concurrent with our clinical practice also. So the result was median onset was about in 70 days, and multivariate analysis confirmed that neutrophil lymphocyte ratio as an independent predictive marker with p-value, with significant p-value. So baseline LNR and low PLR values had higher risk if adverse events had to develop. So to conclude, NLR PLR evaluation may be a useful tool to predict the risk of adverse event. It helps to plan a tailored follow-up during and after treatment with drugs. PLR values at onset may also predict the risk of further toxicity. And if validated, PLR may support the clinical decision of reintroduction of checkpoint inhibitors after discontinuation. This is another paper from Singapore, which has been presented in April 2021. Again, it was a retrospective case control study. The data was collected from June 2014 to September 2013. And these immune checkpoint inhibitors were received until progression or development of unacceptable adverse events or death. Blood counts were done at the baseline at 6 plus minus 2 weeks after the drug administration and at the onset of adverse events. So the data was equally divided in patients with adverse events versus non-adverse events. This graph is important, which shows that lower the NLR. If you can see this horizontal line, this is the median NLR in grade 1 or 2, and this is the median in grade 3 and 4, and the distribution of the neutrophil lymphocyte ratio, if you see, so higher side effects are seen in patients who have lower NLR. So it showed again that NLR less than 3 remains statistically significant in predicting adverse events. In this study, however, platelet lymphocyte ratio was not associated with developments of adverse events. So they concluded that NLR is an independent association with adverse events. It has a bi-directional relationship with adverse outcomes, as I shown you in the previous study also. In this study also, lower the NLR, higher are the chances that the clinical outcomes will be better. That is, median PFS and OS are better in patients who had lower NLR. So NLR is an expensive, readily available biomarkers for predicting adverse events outcome and onset in patient receiving immune checkpoint inhibitors. So I would like to conclude that these all are retrospective studies. We need a larger prospective data so as we are sure and comfortable in prognosticating the patient, and also telling the patient that he might have these side effects because of this predictive biomarkers. Thank you. Back to the organizers.
Thank you. Thank you so much, Dr. Sushant, for such a wonderful presentations. We are actually short of time. And so for the next session, we would like to invite Dr. Kaushal. Yes, sir.
Right. Thank you very much, Sushant, for this excellent presentation. And we'll move on to our next talk, which will be on basically TKI sequencing in EGFR mutated NSCLC. And this will be delivered by Dr. Kaushal Patel, who is a consultant senior medical oncologist and head of department medical oncology at Metas Adventist Hospital and Elite Hemato-Onco Care Center, Surat. So, Dr. Kaushal Patel, over to you.
Yeah, hi, good evening to all of you, and thank you, Amol and team, to invite me. Can you hear me?
Yes.
Okay, so I will start sharing my screen. Fine. So hope you can see my slides also. Yeah.
Yes.
So in this with next a few minutes we will discussing regarding the sequencing of the EGFR TKI in management of the non-small cell lung cancer who are EGFR positive. Basically, we all know that the osimertinib is the base drug and the first to be used in a patient who are EGFR positive patients. But we have some of the data, or we can some of the practical points which shows that we can sequence the treatments to get better result compared to the direct upfront osimertinib. While choosing the drugs, we will consider two main important points in the patients. One is the efficacy and safety of the drugs, and second one is presence or absence of the brain metastasis. To a certain extent, we will calculate the resistance which will be acquired during the treatments of the TKI, and what are the subsequent options of the TKI that will be considered into the considerations. We have basically three generations of the TKI. First generation that consists of the erlotinib and geftinib that will reversibly block the EGFR mutated cancer cells, and it does not have any actions over the T790M mutations. We have second generation TKI that is afatinib and acomatinib. It will irreversibly bind with the EGFR, and along with EGFR, it will be also responsible for the inhibitions of the ERB2 family. So it having a border activity to overcome the certain EGFR resistant, but it does not have any activity against T790M mutations. And third generation TKI, that is the osimertinib, that's irreversible and broadly bind EGFR mutation, and it will be also active against the T790M mutations. Now, how basically while choosing the drugs in EGFR positive patients, if we use the first generation TKI, then at the end of the treatments, or we can say the progression of the disease, the tumor clones become heterogeneous. Some of the tumors clones are EGFR mutated, some of the T790 mutated, and some other they are compound mutations. If we use with broader spectrum second generation TKI, then it will be produced the a homogeneous clone developments at the end of the resistance, and that might be the reason for prolonged PFS has been documented with the second generation TKI. And if you use third generation, then obviously it will come up with the heterogeneous because it left with the very less number of the clones. And if we get the resistance with the TKI, then we have 60% of the patient having a T790M mutations as a baseline factors to get the resistance with the first or second generation TKI. And to a certain extent, we can say that the patient having a MET amplification or MET positivity, some of the tumors will be converted into the small cell malignancy, and very rarely we can say around 10% of the populations which acquired the resistance having a HER2 mutations. So in FLORA study, it has been documented that the resistant mechanism for the osimertinib were predominantly the MET amplifications and to a certain extent EGFR C797S mutations. And in some of the patients, histological transformation into the small cell lung cancer has been also documented in approximately 14% of the patients. Now, if the patient who has been treated with osimertinib, then 47% of the patient receive second line treatments, and out of this, 68% of the patient have no choice but has to get with chemotherapy drugs. While if the patient has been utilized with the first generation or second generation TKI, then approximately 20% of the patient require chemotherapy. Rest of the 80% of the patient can get the second or third generation of the TKI. If the patient has been treated with the first or second generation TKI, and if the progression of the disease has been documented, if the patient is positive with the T790M, then we can go with the osimertinib, and on progression, we can consider the chemotherapy. While if the patient is on osimertinib and progress, then we have no other choice except chemotherapy, and to a certain extent, we can give with the immune therapy also. Now, GeoTag is the study that is a real world study that study the afatinib followed by the osimertinib in a sequential treatments. It's a global observation study across the 10 countries, and the aim of this study is to document the sequential benefit afatinib followed by the osimertinib in EGFR mutated patients. And in this subgroup of the populations, there has been poor performance of the patient has been also included in this study group. And the patient has been initially started with the afatinib as a first line treatments, and on progression, the patient who having T790 mutation has been given osimertinib as a treatment option. The primary point was time on treatments of afatinib as well as osimertinib. And secondary endpoint is a subgroup population study for time on treatments as well as overall survival in different populations. So from here, we can say that the afatinib has been given, followed by the osimertinib on the progression and T790 mutations. Now we can say that the data has been collected. At least 10-month data has been collected only if the osimertinib 10-month prior to the data collections, and there is no cutoff minimal time duration for the afatinib as well as for osimertinib. So there is some of the procedure has been done to reduce the selection bias. Number one is it is a consecutive patients fulfilling the inclusion criteria as included. The enrollment is only limited to the 15 patients per site. The patient who having a brain metastasis as well as little bit poor performance has been also included into the study, and there is no cut off on minimum duration of the afatinib as well as osimertinib use has been included. And because GeoTech study has included the patients who have more than 65 years of the age, there is no restriction on dosage of the afatinib. Some of the patient has been started with afatinib in less than 40 milligram per day. And we can say approximately 15% of the patient in study having a performance status more than or equal to 2. So these are some of the important points which will highlights the utility of the sequencing in the patients. Now, if we see the result of the GeoTech study, then time to treatments, time on treatments with afatinib is approximately 11.9 months, and it's very similar to the PFS which has been documented into the different Lux studies. And if we see the time on treatment for afatinib versus osimertinib sequencing in all subpopulations, then it is approximately 27.7 months. If we go in subgroup evaluations, then we can say that in patient who having a deletion 19, the TOD is approximately 30 months. And if we go with the Asian populations only, then it is 37.1 month. And if we go according to the older populations, the populations who having a 65 years, more than 65 years of the age, the time on treatments is 27.3 months. So it is almost similar to the whole study group. And if we go according to the brain metastasis, then we can say that the patient who having a brain metastasis having approximately TO2 is 22.2 months. That is not bad, and it is more or less comparable with the patient who having an absence of the brain metastasis. And if we go for overall survival as a secondary endpoints, then in whole subgroup or whole populations, then it is 13.7-month OS has been documented into the patient who have been treated with the sequential treatment apatinib followed by the osimertinib. And if we study as a subgroup population evaluation, then we can say that even though in patient who having a performance status more than or equal to 2, the drug sequence has worked nicely, and it is OS has been documented is 32 month. So it is quite good in patient who having a poor performance status. And if we see deletion 19 patients, then OS is approximately 41.6 month. And if we go as a Asian populations, then the OS has been documented 44.8 month. So this is a summary of a geotech study. We can say that time on treatment durations overall it has been documented 27.7 month, and the result has been also documented in all subgroup of the populations, whether the patient is having a brain metastasis, whether the patient is having a poor performance status. Has been also documented into the deletion 19 and L858R mutation also. The predominantly better result has been documented in the patient who having a Asian ethnicity, the good performance status, and deletion 19 and without brain metastasis. But the patient who having a opposite characteristic has been also significantly advantage with sequential treatments. And if we see the secondary endpoint in form of the OS, then it has been also documented better OS in same sequence. But it is much better into the Asian population, deletion 19, good performance status, and without brain metastasis. So which is better TKI prior to the osimertinib, afatinib, or the first generation? That is the main questions right now here. We have one of the paper from the Japan, and it has a retrospective multicentral single country study. It comparing the two group one having a first generation TKI followed by the osimertinib, and group 2 is afatinib followed by the osimertinib. And if we see the result of the two group, then we can say from this table the response rate is quite significantly better into the patient who has been treated with afatinib followed by the osimertinib compared to the first generation followed by the osimertinib. The response rate is more than 80% into the afatinib group versus 50% into the first generation TKI. If we see the progression-free survival, then it has been almost more than double into the patient who has been treated with afatinib compared to the first generation TKI. We have one real world evidence also, and in this we can say we can see from this graph that the median OS is definitely better into the patient who has been treated with the afatinib followed by the osimertinib compared to the gefitinib followed by the gefitinib or erlotinib followed by the osimertinib. And it has been consistently into the all subgroup of the population, either into the exon 19 deletions, uncommon UGFR mutation, or L858R mutations. So we can say from this table, the afatinib followed by the osimertinib is always better than the first generation TKI followed by the osimertinib. We have other study which supporting the sequencing from French as well as Japan, and it has also median time on treatment was approximately 34 month into the French. That is much more better than geotech study, and approximately 49 month or 50 month into the Japan study. That is quite significantly almost more, double into from geotech study. So importance of the sequencing and concept of the chemo-free period is more important into the patient who have EGFR positive, because these are less sensitive to the chemo drugs. If the patient has been treated with osimertinib and then progression, we will give chemotherapy, then total time of the treatment is approximately 38.6 months. If the patient who has been treated with afatinib followed by osimertinib followed by the chemotherapy or immune therapy, then time of treatment duration is approximately 37.6 months. But this data is particularly for the poor performance status. ECOG performance status is 2 or more than 2. And if we go for good performance status, then we can say that the time of total duration of the treatments, afatinib followed by the osimertinib followed by the chemotherapy or immune therapy, whatever it is, it approximately 41 months. So the sequential treatments in good performance status is always better than compared to the osimertinib upfront drugs. In indirectly comparison, we can say that. So this is a very good slides. From this, we can say that the afatinib followed by the osimertinib is best possible overall survival compared to the all other single agent TKI. Either it is a first generation, second generation, third generation. So it is from this presentation, I conclude that the sequential treatments with second generation TKI followed by the osimertinib is better in all aspect of the treatments, and it is consistent in all subgroup of the populations. Thank you. Thank you for patient hearing.
Yeah, thank you, Kaushal. Thank you for an excellent presentation on TKI sequencing in EGFR mutated NSCLC. We move on to our next presentation, and this is basically a role of afatinib in uncommon mutation, and I'll be presenting this topic. So, yeah. Okay, just let me. Yeah, so Kaushal, before starting, I just want to know, so how in your practice, how you place your TKI sequencing in EGFR? I mean, what's your drug of choice basically? How you place your EGFR TKI sequence, EGFR mutated NSCLC EGFR, this sequencing TKI sequencing?
Amol, are you asking to me?
Yeah, absolutely. I'm
Yeah,
asking you.
frankly speaking, in my clinical practice, I would like to start with the definite either dacomatinib or afatinib, and on progression, the disease, I would like to go with osimertinib. There are two reasons for that. One, the affordability. Definitely, the patients are a very less number of the patients that are affordable for the osimertinib upfront. And second thing, indirectly, we can say that the more and more number of the patient, if we treated with the sequential, then they are getting long duration of the treatments on TKI plus chemotherapy compared to the only osimertinib. So these are the two basic reasons by which I would like to go with the sequential rather than osimertinib direct.
Yeah, absolutely. So even I don't prefer to directly start with osimertinib, and because we always need, what next.
Yeah.
So I'll thank you, Kaushal. I'll move on to my presentation on role of afatinib with uncommon mutations. So if we see that EGFR mutation in non-small cell lung cancer, almost around 45 to 62% of the patient have this exon 19 deletion, which is the most frequent EGFR mutation. The common deletion 19 and L858R mutation, followed by around 33 to 40% of the patient having exon 21 mutation, which is L858R, and around 10 to 15% of the patient, they have tumors that harbor uncommon EGFR mutations, comprising of mutation in exon 18 to 21. So we are very clear about this part of the this patient's molecular profile. But what about these 10 to 15% who just harbors this uncommon EGFR mutation, be it a single point mutation or be it combination mutation? But definitely we need to look into these also. Even though we are very happy seeing, okay, this patient is mutation positive and patient is need not to take chemotherapy initially, but then we also need to be very sure that, okay, if these are the uncommon mutation, then how good we are gonna increase their PFS, OS, whatever. So there is recent improvement in detection methods that have indicated that uncommon EGFR mutations are more prevalent than previously thought. Furthermore, around 25% of the patients have compound EGFR mutation, that is more than 2 independent mutations. And according to the COSMIC database, around 594 types of EGFR mutation had been reported. Now, these heterogeneity of these EGFR mutations in EGFR mutated NSCLC has potential clinical implications. First being, we know very little about the sensitivity for this uncommon or compound mutation. And second, different EGFR target TKS can have different activities against specific mutation, and that is what this lecture is about. So, let us go to some preclinical evidence about these uncommon mutations, and then we'll see which drug and what to be given. So these are the in vitro activity of some uncommon EGFR mutations, EGFR TKS against uncommon EGFR mutation. So you can see on the left side, this is the diagram which shows that the percentage cell viability on the y-axis, and these are the micromole concentration on the x-axis. So you can see in L858R mutation, which is a common mutation, you can see afatinib concentration on 0.001. This is for the osimertinib and this is for the gefitinib. But if you see for the L858 with L861Q, that is the combination mutation, which we consider as a uncommon EGFR mutation, and you can see the dosing of osimertinib and the gefitinib, it increases almost to the log of 10. But if you see the afatinib log, it is just more or less at same point, around 0.01. So again, if you see the maximal inhibitory concentration, that is IC50. So if we consider the L858R and if we consider the dosing for each erlotinib, afatinib, osimertinib as 1. So for this uncommon mutation, that is the L861Q and S7681, the maximal inhibitory concentration needed for erlotinib is almost 20 times, and for S768I mutation, it is almost 32 times the dose of erlotinib. Whereas if you see for osimertinib, again it is almost 3.6 times the dose needed for a common L858R mutation, whereas for the dose of osimertinib is almost 20 times for the uncommon S768I mutation. But if you see the afatinib, you can see here it is just 2.5 times for L861Q and it is around 3.5 times for the 7681. Basically, the purpose of this slide is just to tell you that the afatinib concentration or the potency of afatinib is better even in this uncommon EGFR mutations. So the first and third generation TKS demonstrated reduced activity against cell lines harboring uncommon mutation, whereas the response to afatinib was similar across cell lines. So that is the main. So this is the preclinical. Then again, the sensitivity of TKS to various EGFR mutations by Mano method. Now you can see this blue indicates sensitive, yellow is partial sensitive, and pink one is resistant. So you can see around exon 18 to exon 21, you can see this afatinib. There's almost everywhere it is a sensitive. And these, mind you, these are all uncommon mutations, EGFR mutation, except for this L718Q, where you can find that even afatinib is resistant. All the 4 drugs are resistant. But you can see it here that afatinib is almost sensitive to most of the uncommon EGFR mutations. Okay. Then except for this exon 20, where there is, you find this. And again, this is for the single uncommon mutation. And if you see the compound mutations, again you can see, except for this T790M, where we know what is the drug of choice, this, except this T790 variants, you can see afatinib even in common mutations has a highly it is very sensitive. So afatinib is sensitive in most of the uncommon and compound EGFR mutations compared to first and third generation TKS. So this is something about the preclinical evidence. Now coming to the clinical evidence. Now we all know about the LUX-Lung clinical trials and eligibility. So all this LUX-Lung 2, LUX-Lung 3 and LUX-Lung 6, they're almost, there are almost 75 patients who harbor these uncommon mutations and who are being treated with afatinib. So in LUX-Lung 2, which is a phase 2 trial, around 23 patients. 23 patients have uncommon mutation which are treated with afatinib. In Lux Lung 3, there are 26 patients. There are 37 uncommon mutations, out of which 26 patients have been treated with afatinib. And in Lux Lung 6 phase 3 trial, around 40 patients have uncommon mutation, out of which 26 patients were treated with afatinib. Now we just this patient been divided into 3 subgroups. So group 1 are the patients who have point mutation or duplication exon 18 to 21. There are different mutations, L861Q alone, or there are different mutations, uncommon mutations. Whereas the group 2 are those who have de novo to T790M alone or in combination with other mutations. Whereas group 3 is the exon 20 insertions. So we have in these 3 groups, the number of patients are 38, 14, and 23. Now, so the objective response and disease control rate by independent review. So in group 1, which comprises of point mutation, duplication, exon 18 and 21, you can see with afatinib, the objective response rate is around 71.1%. So out of 38, 27 patients had very good response. Then in group 2, that is a de novo T790M, the the objective response rate is around 14.3%. And in group 3, that is exon 20 insertion, the objective response rate is around 8.7%. If we see the median duration of response, again in group 1, it is 11.1 months compared to 8.2 months in group 2 and 7.1 months in group 3. If we see the disease control rate, DCR, again it is around 84% in group 1, whereas it is 64% in group 2 and 65% in group 3. So this is the randomized control in patients with uncommon EGFR mutation, a total of 75 patients from these 3 trials. Yeah. Now again, if we see the tumor shrinkage in patient with uncommon mutations by independent review, so you can see this is a waterfall. The post hoc analysis showed that most patients with point mutation, that is the group 1, with duplication of exon 20 inside, had tumor shrinkage when treated with afatinib. So you can see this, there is a definite tumor shrinkage with the use of afatinib in group 1 patient with point mutation duplication, and there's some amount of tumor burden reduction even in patients with exon 20 insertions, and group 2 with de novo T790M mutation. So coming to the activity of afatinib population specific uncommon, if we now again see the activity of afatinib in population specific uncommon EGFR mutation, now the G719X, okay, so the overall response rate is around 78% with a median PFS of 13.8 and median OS of 26.9 in G719X, whereas in L861Q mutation, the median OS is around 17 months with median PFS of 8.2 months and overall response rate of 56%. Whereas in S768I, it is not estimable. The median OS is not estimable, whereas the median PFS is 14.7 months with 100% response rate. So the afatinib exhibit efficacy in major uncommon EGFR mutation, that is G719X, L861Q, and S768I. Now we just compare
sir, Sir, apologies. You've got last 1 minute to complete.
Yeah. So if we see the osimertinib in lung cancer with uncommon EGFR mutation, this is an open label phase 2 trial in 36 patients with NSCLC harboring uncommon. You can see the overall response rate with osimertinib in this uncommon. We have a overall response rate. If we see a mutation type, it is just 37.5 for S768, G719 it's 52, and L861Q it's 77.8. Even median PF is just 8.2 months. So coming to the real world analysis, this is the first clinical activity retrospective single center data where 56 stage 3B4 lung adenocarcinoma patients uncommon mutation who received EGFR TKI treatment. So you can see the first generation TKI, the median PFS is around 5 months, whereas for with the second generation TKI, the median PFS is around 15 to 16 months. Similarly, in the major uncommon mutations, you can see the median PFS is somewhere around 5 months, whereas with the second generation TKI, median PFS almost up to 20 months. So in all uncommon mutation groups, including compound mutations, the afatinib exhibit longer median PFS compared with first generation TKI. So the afatinib for treatment of NSCLC harboring uncommon EGFR mutation, it is a database of 693 cases, and you can see of the 693 cases, 315 were TKI naive patients, and you can see around 272 patients have these major uncommon mutation. And if you see the time to treatment failure, this is almost around 10.8 months, whereas with the compound mutation, the median TTF is around 14.7 months. So again, you can see the time on treatment with the TKI naive patients. You can see the median TTF is time on treatment is around 16.6 months for patients who have compound containing major uncommon mutation. It's 15.6 months for patients who have 768I mutation. So the major uncommon and compound mutation afatinib shows stronger activity with overall response rate of more than 60%. With exon 20 insertion, afatinib demonstrates durable response in some patients. So again, this is the overall survival in uncommon EGFR mutations. We can see the median PF is around 11.1 months with OS of 25.6 months with the use of afatinib. You can see this Kaplan-Meier curves for both OS and PFS. This is again a retrospective study. So, yeah. So to summarize, are all TKs same in uncommon mutations? You can see with erlotinib, gefitinib, overall response rate around 58.4 months with PFS of 5 months. With osimertinib, open label single arm trial, overall response rate around 50 months with PFS of around 8.2 months. But with afatinib, both in Lux-Lung series and pooled analysis, you can see the overall response rate in the range of 60 to 71 with PFS of around 11 months and time on treatment is around 10.8 months. So with this, I finish my talk and thank you very much for this. Basically, this session is sponsored by Boehringer, and thanks for the update analysis on this uncommon mutations and role of afatinib. Thank you. Yeah, so we'll move on to our next session, which is a talk on unmet needs in ALK treatment landscape. And for this, I would like to call upon Dr. Pushpak Chirmade, who is the Director and Concerned Medical Oncologist at Oncura Hematology and Oncology Care, Mumbai. Dr. Pushpak, please.
Yeah, thank you, Dr. Alok. A really wonderful conference, exhaustive and really informative. Can the organizers enable screen sharing for me? Yeah, that's it. Is the screen visible?
Yeah.
Yeah. Okay. So without wasting any time, I'll proceed with the slideshow. Just a minute. So basically the topic that I would like to discuss now is addressing the unmet needs of ALK treatment landscape. So we all know that EGFR, if compared to ALK is a very small subset, but a very important subset, because the treatments that we have for ALK for mutated lung cancers are really wonderful, and the responses that we see with them is phenomenal. So what is the need for these ALK inhibitors? So ALK mutation in lung cancer is about 7% of the total existing mutation burden. Driver mutation and non-driver mutations included. So we know that the big player here is EGFR mutation, sensitizing about 17%, and the other EGFR about 4%. And the next important driver mutation is ALK, and that is why in clinical practice we check EGFR and ALK is the most common type of mutation studies that we do. This is a very recent discovery that we came to know about ALK. 2007 was the time when we came to know about the EML4 ALK translocation that was a driver mutation in lung cancer. In 2012, crizotinib, the first inhibitor, was established. In second generation inhibitors like ceritinib, alectinib, and brigatinib were approved in 2015. Second generation ALK inhibitors like alectinib and ceritinib were approved for first line use in 2017. And now we are in the era of third generation ALK inhibitors, that is lorlatinib, and the drug is wondrous. So what are our options for the first line treatment of ALK positive NSCLC? What is the current status? So the current status, to be really brief here, is guidelines recommend that we start with second or the next generation ALK inhibitors, preferably alectinib. The study that supports this is the JALEX and the ALEX study, which has a good overall survival data, and it is also a very tolerable drug. The other studies which support the other generation of ALK inhibitors, so the Profile 1014 study for crizotinib, versus chemotherapy, wonderful numbers. 10.9 versus 7 months. The median was the median PFS. The PFS as 18 months was 31 versus 5%. The overall response rate was 74 versus 45%. So definitely crizotinib was the first drug approved here, which was compared against the standard of care at that time, that was chemotherapy. Then came ceritinib. Ceritinib was the ASCENT-4 trial. Median PFS 16.6 versus 8.1 months. PFS at 18 months was 50 versus 23. This was compared again with chemotherapy, and it got the approval because the overall response rate was 72 versus 26 months, 26%. Then came the ALEX trial. It was compared with the standard of care crizotinib at that time. A wonderful trial design. The PFS was the overall response rate was quite significant. The median PFS was not reached versus 10.9 for crizotinib. The hazard ratio was 0.43 and it was statistically quite significant. It was also effective in the CNS Mets. So the hazard ratio for CNS Mets was 0.35, and those which did not have CNS Mets, the hazard ratio was 0.47. So definitely alectinib established itself as a bigger and a better player than crizotinib, and according to the guidelines, it's the #1 choice that we have for ALK positive NSCLC. Then came brigatinib, one of the latest players in the game. ALTA-1 L trial. Again, brigatinib versus crizotinib, the promising data for brigatinib. You can see here that the percentage PFS, the hazard ratio was 0.49 and was statistically significant at 0.001%. The OS analysis, so the graphs previous were the PFS graphs. Now the OS analysis, so this was chemotherapy versus crizotinib, the profile 1014 primary OS analysis. Again, crizotinib definitely being favored here, though the confidence interval was exceeded by the line of unity. The hazard ratio was 0.76, but the p-value was 0.09. But the ALEX 5-year data, this was the turning point where we can see the OS data remained, though immature, with 37% of events recorded. The hazard ratio was 0.67 with the confidence interval of 0.46 to 0.98. The median age for OS was not reached with alectinib versus 57.4 months with crizotinib. So it was a significant change where we had an overall survival. Though data was immature, it definitely tended to a good overall survival. Now, what is the unmet need in this ALK mutated lung cancer treatment landscape? So the questions that we need to answer are, why do these patients progress? So we have seen that the patients progress on first generation crizotinib, the patients also progress on the second generation crizotinib. So do they develop resistant mutations? And if they do, then how to overcome them? The second most important question is which is the side of progression? So which side do these ALK mutated lung cancer patients progress? And what we came to know that CNS is the most resistant and the most troublesome side. So the two challenges which I can say are resistant mutations, because patients ultimately develop resistant to ALK TKIs due to resistant mutations, which are around 53 to 71%. That's quite a high number. Amongst all the resistant mutations, 29% develop the notoriously poor performer, that is the G1202R mutation. And this is true especially more for the next generation ALK inhibitors. So alectinib, ceritinib, these are more prone to develop this resistant mutation. The next problem line is CNS metastasis. Around 80%, about 60% of ALK positive patients present with brain metastasis upon progression after treatment with ALK inhibitors and are associated with poor prognosis. So to address this unmet need, what do? We have a new molecule on the block, lorlatinib, an absolutely wonderful molecule with evidence for next line therapy, as well as now a recent evidence with the CROWN trial establishing lorlatinib as first line therapy also. So what does lorlatinib do differently? So it is a more potent inhibitor, it is more penetrant into the brain, and it has a high affinity to most ALK resistant mutations. So resistance hai, lorlatinib is an answer. CNS Mets are there, lorlatinib is an answer. These were the preclinical data. They had an extensive study to evaluate it preclinically, where the patients were divided into expansion cohorts, depending upon whether they had received previously chemotherapy or crizotinib or a next generation TKI. ALK TKI, and in this even brain metastatic patients were included. The overall response rates, if you can see, so the three primary cohorts were the expansion cohort 2 and 3A, expansion cohort 3B, and expansion cohort 4 and 5, where it was prior crizotinib, non-prior crizotinib, but ALK TKI, and more than 2 lines of prior ALK TKIs. So overall response rate with lorlatinib was better and good in almost all the subtypes of expansion cohorts. So the overall response rate in prior crizotinib was 72.9%. The non-crizotinib ALK TKI plus minus chemotherapy was 42.9%, and more than 2 lines of prior ALK TKIs was 39.6%. The duration of response was also quite significant. So it was median not reached versus 5.6 versus 9.9. So all were statistically significant. If we move ahead, phase 2 trial of lorlatinib efficacy in patients with more than or equal to 2 prior ALK TKIs plus minus chemotherapy. So in these highly treated cohorts also lorlatinib had a good response. So the overall tumor response in these wonderful waterfall plots, we can see that almost 80% of the patients had some sort of response, with about 20% having stable disease and more than 20% having partial response. The intracranial response was also very significant. So definitely a drug which can be used in these common patients who have progressed in the CNS and good activity there. So mechanisms of acquired ALK inhibitors, acquired resistance to ALK inhibitors. So we know that though the primary or the first line ALK inhibitors demonstrated high activity in ALK rearranged NSCLC, disease progression occurs at the median of 10 to 25 months. Mostly it has isolated CNS mets. The mechanisms are ALK amplifications, ALK mutations, bypass pathways, and efflux pump in the CNS. Now, these are the various mutations which are seen, and more resistant mutations after treatment with second generation ALK inhibitors, including difficult to treat G1202R mutation. So the second generation was more difficult to treat mutations, and hence a very important unmet need that we need to address. Now, this is a wonderful graphic here. If you can see at the rightmost column, it's lorlatinib, and most of the common ALK mutations all are sensitive to lorlatinib with an IC concentration, IC50 concentration of less than 50 nanomoles. So a sensitive drug. And the next question here that arises is it good and tolerable drug also? So we will see that in the later slides. So ALK resistant mutations and efficacy of lorlatinib in advanced ALK resistant mutations and efficacy of lorlatinib advanced ALK positive NSCLC. So if we can move here a little fast. So lorlatinib had action even in patients who had resistant mutations to the second generation TKIs. So those who had a response to ceritinib with ALK alteration among patients with crizotinib resistance, lorlatinib did well. So previously treated patients with crizotinib, efficacy of lorlatinib was comparable in patients with or without ALK mutation. So a resistant mutation was not necessary to establish to change over to lorlatinib. So lorlatinib was actually effective in patients who had progressed on crizotinib, and there was no need to actually prove that they had developed a resistant TKI mutation. The patients who were previously treated with more than one second generation TKI, again, a good overall response rate, a total outcome measure overall response rate was 40%. And they had divided in this study those who had a mutation positive with plasma genotyping versus mutation negative, and even tissue genotyping levels were considered. And in all these cases, if you had a second generation TKI that was used in one line, then a mutation positive patient had an overall response rate slightly better than the mutation negative one. But even at that case, there was a 40% overall response rate that was seen. Lorlatinib demonstrated anti-tumor activity against all the 5 most common ALK mutations. So G1202R, the overall response rate was quite high. It was 57. And the other mutations, the response rate was even better. So moving ahead, in patients who had failed more than one or equal to one second generation ALK inhibitor, the number of ALK resistant mutations, that is compound mutation, may affect the efficacy of lorlatinib. But larger studies are required to validate this finding. So this was an interesting observation that compound mutations, lorlatinib would not be able to act that better, but in single mutations, lorlatinib would act good. So that is an important point, that lorlatinib probably, if we can introduce early in the treatment when the patients have not yet developed compound mutations, that can benefit the patients in the long run. Now the brain penetration data, if we can see here the two graphs, patients with baseline CNS mets, patient without baseline CNS mets, lorlatinib was able to control both the populations from the development or progression. This was comparing patients with baseline CNS mets and patients without baseline CNS mets when they had received prior second generation TKI. Again, lorlatinib was able to prevent progressive CNS disease. Moving ahead. So lorlatinib anti-tumor activity in previously irradiated brain lesions that were in progression at the baseline. So even in patients who had previous brain irradiation, lorlatinib had an objective response rate that was quite significant, with the median duration of intracranial response not reached. And if prior second generation TKI, it was 12.4 months. So that was quite significant. The clinical management of adverse events with lorlatinib, so most common are dyslipidemias, hypercholesterolemia, hypertriglyceridemia. The important one here and a different one here is the cognitive effects. So cognitive effects were there, but the percentage was only 1.7%, probably correlating with the improved penetration into the CNS. Moving ahead, summary, lorlatinib showed a clinically meaningful benefit in pre-treated patients with ALK positive NSCLC, including those who had received prior crizotinib, only one second generation TKI, or up to 3 prior ALK TKIs. So lorlatinib does play a role in all the categories of patients, especially the resistant mutation, that is the G1202R mutation, was more susceptible by lorlatinib. Responses were observed in patients without detectable ALK kinase domain mutations also. Lorlatinib was generally tolerable with low incidence of permanent discontinuation due to adverse events that were manageable through dose modifications and supportive therapy. So metastatic ALK positive lung cancer, what would be our choices? So first line therapy, alectinib. Second line therapy, probably lorlatinib. Now, this was the recent trial, that is the CROWN study that was presented in ESMO 2020. Here, lorlatinib was established or evaluated for first line treatment. It was compared with crizotinib, lorlatinib 100 milligram QD versus crizotinib 250 milligram BID. And we can see here the primary endpoint was PFS, and the PFS was quite significant. The advantage was the median PFS was not achieved versus 9.3 months, with a hazard ratio of humongous 0.28, which was statistically quite significant. So definitely lorlatinib, that is the third generation TKI, would make its way in first line treatment also, if we are able to manage the side effects much better. With this, I'll end my presentation. Over to you, Dr. Amol Dongre. Thank you for this opportunity.
Hello, thank you very much, Dr. Pushpak, for this nice presentation on unmet needs in health treatment landscape. So with this, we come to today's exhaustive